Welcome to Vitals and Beyond, and to this in-depth masterclass on how to read arterial blood gases, or ABGs. Whether you're a student, nurse, or physician, understanding ABGs is crucial for managing patients with respiratory or metabolic imbalances. In this video, we'll break down everything step by step, so you'll never feel lost when interpreting an ABG again. An ABG, or arterial blood gas, is a test that measures the pH, so the acidity or alkalinity of the body, PaCO₂, which is partial pressure of carbon dioxide, PaO₂, which is partial pressure of oxygen, HCO₃, which is bicarbonate, and SaO₂, which is oxygen saturation. So why is it so important? It helps us assess the oxygenation status, ventilation, which means the CO2 removal from the body, and the acid-base balance. Common indications for an arterial blood gas analysis are respiratory distress, shock or sepsis, suspected acid-base disturbance, or monitoring critically ill patients. We're now looking at the normal ABG values. The pH should be between 7.35 to 7.45. The carbon dioxide should be between 35 and 45. The bicarbonate should be between 22 to 26. The PaO₂ should be between 80 and 100, and the saturation should be above 95%. The balances between acids and bases is critical. A pH below 7.35 is acidemia, and above 7.45 is alkalemia. CO2 is acidic, while bicarbonate is alkaline. CO2 reflects respiratory functions, while bicarbonate reflects metabolic functions. The body maintains pH through buffer systems, which are especially bicarbonate, lungs, who control carbon dioxide, which is a fast response, and the kidneys, who control the bicarbonate, which is a slow response. For example, hypoventilation is causing carbon dioxide retention, which will result in a respiratory acidosis. Hyperventilation will cause a carbon dioxide loss, which will result in a respiratory alkalosis. Diarrhea causes a lot of bicarbonate loss, which will cause a metabolic acidosis. We have to go through a couple of steps to interpret an ABG. Step 1 is check the pH. Is it below 7.35? Then it's an acidemia. Is it above 7.45? That's an alkalemia. Step 2, check carbon dioxide. Is there a high carbon dioxide? It's a respiratory acidosis. Is there a low carbon dioxide? Then it's a respiratory alkalosis. Step 3, check the bicarbonate. Is there a low bicarbonate? Then it's a metabolic acidosis. But if there's a high bicarbonate, then it's a metabolic alkalosis. Step 4 is matching the pH with the primary abnormalities. If the pH is low and the carbon dioxide is high, then it's a primary respiratory acidosis. If the pH is low and the bicarbonate is low, then it's a primary metabolic acidosis. Step 5 is checking for compensation. Is the opposite system trying to fix the pH? Compensation never overcorrects the pH. Step 6 is calculate the anion gap if it's a metabolic acidosis. The anion gap is a number that helps doctors figure out why someone has too much acid in their blood. The formula is simple. It's sodium minus the chloride plus bicarbonate. You just subtract the amount of chloride and bicarbonate from the amount of sodium in the blood. A normal anion gap should be between 8 to 12 milliequivalents per liter. A high amount suggests accumulation of acids, for example, lactic acids or ketones. A normal number will indicate lots of bicarbonates, by example diarrhea. Step 7 is assess oxygenation, so the PaO₂ and the saturation. A low PaO₂ is hypoxemia. Could be caused by ventilation-perfusion mismatch, shunting, diffusion defects, or hypoventilation. We now go through some examples. For the first one, the pH is 7.29. The CO2 is 50. and the bicarbonate is 24. What do we see? The pH is low, so this is acidosis. The CO2 is high, meaning the lungs aren't removing enough carbon dioxide. The bicarbonate is normal, so the kidneys haven't had time yet to fix it. This means it's an uncompensated respiratory acidosis caused by a lung problem. Possible cause could be COPD, respiratory depression, or an airway obstruction. In example 2, we have a pH of 7.48, a carbon dioxide of 33, and a bicarbonate of 23. What we're seeing here is that the pH is high, so this is an alkalosis. The carbon dioxide is low, meaning the person is breathing out too much carbon dioxide, like when hyperventilating. The bicarbonate is still normal, so the kidneys haven't adjusted yet. This means it's uncompensated. The interpretation of this blood gas is a respiratory alkalosis, which is still uncompensated. Possible causes could be anxiety, pain, fever, or early stage of sepsis. Example 3. The pH is 7.31. The carbon dioxide is 28. The bicarbonate is 14. What we're looking at is a low pH, so it's an acidosis. The bicarbonate is low, meaning the body has lost base or gained acid, which is a metabolic acidosis. The carbon dioxide is also low, which means the lungs are trying to help by breathing faster and blowing off acid, which is compensating. So the interpretation is a metabolic acidosis with respiratory compensation. Sometimes you'll have 2 or more disorders at once. The clues are that the pH is normal, but both carbon dioxide and bicarbonate are abnormal. You're speaking of a mixed disorder then. If compensation seems too good or inadequate, it's a suspected mixed. For example, a pH of 7.38, a carbon dioxide of 55, and a bicarbonate of 32. It's a mixed respiratory acidosis plus a metabolic alkalosis. If we take a look at the common causes by an ABG pattern, a respiratory acidosis is commonly caused by COPD, neuromuscular disease, or sedation. A respiratory alkalosis is often caused by hyperventilation, anxiety, or sepsis. A metabolic acidosis is often caused by a diabetic ketoacidosis, renal failure, or diarrhea. And a metabolic alkalosis is often caused by vomiting, diuretics, and antacids. Let's recap how to approach any ABG. 1. Look at the pH. 2. Determine if respiratory or metabolic. 3. Check for compensation. 4. Calculate the anion gap if needed. 5. Assess oxygenation. And 6. Consider the clinical picture. Final tips: always interpret ABGs in the clinical context. Don't forget to correlate with electrolytes and lactate. Practice with real cases to build confidence. Thanks for watching. We hope this deep dive into arterial blood gases has helped you feel more confident in interpreting ABGs in any clinical settings. If you found this helpful, don't forget to like, subscribe, and click the notification bell so you'll never miss out another medical explainer. See you next time!